My pleasure now to introduce Dr. Tim Wilkin from Weill Cornell Medical Center in New York City. He has been involved in HIV care, but especially in the complications and comorbidities, and with a special focus on cancer. As we all know, cancer complications of HIV have been around since the beginning, original KS and lymphoma reports, but things have changed over 40 years. And Dr. Wilkin's going to take us through what's going on in today's world with our patients, especially those on successful antiretroviral therapy, and what we can do about it. So Tim, welcome, and look forward to your presentation.
Thank you. I'm having a little trouble starting my slide.
We can see the slide. Just
Oh my God, it's my worst nightmare coming through.
Oh, not to worry, Tom. Thank you.
Yay, there you are.
Okay, thank you, Mike. I really appreciate it. I wish I was there in person. I wish we were all there in person, but I'm happy to join you today online. So I'll be talking about an update on screening for non-AIDS defining cancers. Here are my financial disclosures. So in this talk, I hope at the end of the talk, you'll be able to describe some overall trends in non-AIDS defining cancers for people with HIV, to list some non-AIDS defining cancers with increased incidence in people with HIV, and to implement appropriate screening for non-AIDS defining cancers. As Mike said at the beginning, cancer's been part of the HIV epidemic from actually the very first report. So along with pneumocystis, the original report described Kaposi sarcoma. And over time, we've noticed with the advent of effective antiretroviral therapy, AIDS-defining cancer as the major problem for people with HIV has declined pretty dramatically. In the black line, you can see the overall incidence rate, as well as in the bar graphs, the total number of AIDS-defining cancers. And you can see that they've declined pretty dramatically with effective antiretroviral therapy and have stayed low since then. It's really a much different story when you look at non-AIDS defining cancers. So overall, if you look at the age-adjusted incidence rate of non-AIDS defining cancers for people with HIV, it's gone down slightly over time. And that mirrors what has happened in the general US population. However, with effective antiretroviral therapy, people with HIV are living much, much longer. And most of our patients are over the age of 50 now. And as people age, their risk of these cancers goes up pretty dramatically. So while the age-adjusted rate has stayed pretty level or declined, the burden, the overall number of cases has gone up pretty dramatically over the years. So when we look at the different types of cancers, we see the different relationships with HIV. So of course, AIDS-defining cancers are exquisitely elevated in people with HIV. For example, Kaposi sarcoma, which you can see sometimes in older men without HIV, the rate is 500 times higher with people with HIV. A similar story, less dramatic, with non-Hodgkin's lymphoma and cervical cancer, which has also been classified as AIDS-defining cancer, has just a relatively modest increase, about threefold higher for women with HIV. When we look at non-AIDS defining cancers, there's really two stories going on. The first is related to virally associated non-AIDS defining cancers, where I spend the majority of my research career about prevention of HPV-related cancers. So you can see for a variety of HPV-related cancers, such as oropharyngeal cancer, anal cancer, vaginal, vulvar, and penile cancers, there's a marked association with HIV. Other virally associated cancers include liver cancer, which is associated with hepatitis B and hepatitis C, and Hodgkin's lymphoma associated in some cases with EBV. So all of those virally mediated cancers have an increased incidence in people with HIV. However, other non-virally mediated cancers, such as breast, colorectal, and prostate, are not elevated in people with HIV. There really doesn't seem to be any increased incidence, in some cases a slightly reduced incidence. But I want to draw your attention to lung cancer. So it's really a common cancer problem that we see in our patients. And people with HIV have doubling the rate of lung cancer as compared to those without HIV. Now, the reasons for this are probably multifactorial. Certainly, we all know that people with HIV have a tendency to smoke, and high rates of tobacco use and prolonged tobacco use and difficulty stopping tobacco certainly contribute to this elevated risk. However, that doesn't explain the entire risk. So a number of studies have looked at the relationship of immune suppression to HIV or to lung cancer, and prolonged immune suppression certainly raises the risk of lung cancer. There's additional thoughts that perhaps HIV itself can interact with key cells in the lung to raise the risk of lung cancer. And there's interesting associations with just even pneumonia causing inflammation and leading to an increased risk of lung cancer for years after an episode of pneumonia. So just skipping ahead, I want to make sure that everyone is well aware of the indications for screening for lung cancer, as that seems to be underutilized in our clinics. So with these increased risks of non-AIDS defining cancer, this is a leading cause of death for our patients. So several studies have combined cohort analyses have reported that the rates of non-AIDS defining cancer, or the proportion of deaths related to non-AIDS defining cancer, has increased over the years. And in some cases, up to 15% of deaths are related to these cancers. And when someone with HIV is diagnosed with cancer, there's disparities that we observed. So this study from Anna Coghill looked at a variety of cancers and adjusted for the stage of diagnosis. So compared people with HIV diagnosed with a particular cancer at a particular stage and compared their mortality to similar people without HIV. And for almost every cancer, there was a significantly increased risk of cancer-related mortality for people living with HIV. So the mechanism of this, whether it's poor response to treatment, poor access to treatment, poor tolerability of treatment, is really not well understood, but a reality of our patients diagnosed with non-AIDS defining cancers. So just to summarize this first half, there's an evolving cancer burden in people with HIV. The rates of AIDS-defining cancers, fortunately, like Kaposi sarcoma, non-Hodgkin's lymphoma, have declined with widespread effective HIV therapy. But despite this therapy, people living with HIV remain at higher risk for many cancers, particularly infection-associated cancers, and in addition, lung cancer that we've talked about. These non-AIDS defining cancers not linked to infection are now more common for people with HIV, and this reflects the aging of our populations due to effective therapy. And one result of these changes is that non-AIDS defining cancer is now a leading cause of death for people living with HIV. So now we're going to move on to talk about prevention. And first off, we'll talk about active screening strategies. So if you do just general primary care, you can take heart that in general, the screening for people with HIV is the same as for people without HIV. So specifically for breast cancer, colorectal cancer, and lung cancer screening, the recommended screening algorithms are the same for people with and without HIV. The additional cancer that the U.S. Preventative Health Task Force, which I would say is probably the most conservative as far as recommendations for cancer screening strategies. The fourth cancer they recommend screening for is, of course, cervical cancer. So we're not really going to discuss the details of that today, but in general, the strategies for cervical cancer prevention are the same for women with HIV as those without. there's perhaps just a bit more intense follow-up, and some of the actual screening algorithms are not as well studied in women with HIV, but generally the approaches are similar. Many of us may choose to screen patients for prostate cancer, especially those with a family history. And there are some guidelines or groups that recommend prostate cancer screening after intensive counseling, this shared decision-making approach, but it's actually not one of the recommended cancer screenings by the U.S. Preventative Health Task Force. So I want to spend a few moments to talk about lung cancer screening. So the concept for lung cancer screening is to have an active screening approach that diagnoses lung cancer at earlier stages. And we know from a variety of studies that lung cancer diagnosed at the earliest stages actually has a much better survival. So if you look here on the right at these myriad of lines, what you can see at the top, or this is a 6-year survival curves from the time of lung cancer diagnosis. And so at the top, you see those diagnosed with the earliest stages of lung cancer, and then slightly progressive stages moving down. And you can see if you can diagnose lung cancer at these very early stages, the 6-year survival is quite good. And so that's really the goal of lung cancer screening. So who should be screened? The current recommendations are those 55 and older, those that are current or former smokers, and former smokers being within 15 years of quitting smoking, where your elevated risk of cancer persists for 15 years after quitting smoking. They have to have at least a 30 pack year history, and there's no sign of lung cancer. If somebody has a sign of lung cancer, shortness of breath or hemoptysis, something like that, then they really need diagnostic evaluations rather than a screening test. So the recommendation for the screening test was based on the National Lung Cancer Screening Trial. So this actually randomized 54,000 patients to one of two strategies. One was a screening strategy with 3 yearly low-dose CT scans. And the control group, although this isn't something we actually use in practice, was chest x-rays, 3 yearly chest x-rays. And so if there were abnormalities on the evaluations, then people went forward for diagnostic procedures, often invasive diagnostic procedures. And interestingly, the vast majority of these initial screen positives, of these initial abnormalities, were not in fact cancer, but some were. And so the way that the study turned out is, if you look at the left here, is that the CT screening arm diagnosed more cancers at an earlier stage. So I have circled these early stage 1A, 1B, 2A to 2B lung cancers that were diagnosed in the CT screening arm, whereas a fewer number of these cancers were diagnosed in the chest x-ray screens, and more cancers were really diagnosed without screening. And so overall, this led to a reduction in a 20% reduction in lung cancer mortality for the low-dose CT screening group. And so in this study, it was estimated that you would need to screen 320 people to prevent one lung cancer group or death. Now, keep in mind that this is not everybody getting screened for lung cancer. These are people that are at particularly high risk for lung cancer based on their smoking history. So when we talk about people with HIV and low-dose CT scanning, there's really very few studies that have investigated this. So there does seem to be, in general, it seems to perform similarly as what was described in these studies. But you would be concerned for someone with HIV, they'd be more likely to have abnormalities on imaging, more likely to undergo invasive screening or invasive testing to diagnose a lung cancer. So I do think this is an area that needs to be researched further, and certainly something that we need to figure out, perhaps on the programmatic levels. How do we encourage the screening and really facilitate the screening for this important cause of cancer death for our patients? So other cancer prevention activities that we are recommended in the US, there's hepatocellular carcinoma. So the way that we prevent this, one is to prevent these infections in the first place. So vaccination against hepatitis B and other prevention practices, clean needles to prevent acquisition of hepatitis B and hepatitis C, screening for hepatitis B and C and treating hepatitis B and C will reduce the rates of cancer. And then for those, especially those who have cirrhosis, there are recommended screening strategies to look for hepatocellular carcinoma so that it can be found early and treated. Something that I spent a lot of time working on is HPV-related cancers. So 9-valent HPV vaccination is recommended for prevention of anal, cervical, oropharyngeal, penile, vaginal, and vulvar cancers. I'll talk a little bit about oropharyngeal data in just a moment. And certainly a lot of us spend time trying to get our patients to stop smoking or reduce their tobacco use. And there's a couple other cancer prevention activities that are recommended by the US Preventive Task Health Force, including aspirin use for those at high risk for MI, where the risk-benefit ratio is favorable to prevent colorectal cancer. And there's also certain breast cancer strategies to reduce the risk of breast cancer. So to talk about anal cancer for a moment, which has been notably absent from the discussion. So this is a cancer that's a very elevated rate of cancer among people with HIV. To give you some context, these rates that we see in people with HIV are higher than the rates of cervical cancer in the US now, certainly, and higher than the rates of cancer prior to widespread Pap smear screening. So HPV cancer starts with an HPV infection. The infection can persist, and the areas of persistent infection, you can develop dysplastic lesions, lesions at risk for turning into cancer, also called HSIL or high-grade squamous interepithelial lesions. If these are left untreated, some of these will progress to invasive cancer. So for people with HIV, they have a higher HPV exposure based on their sexual histories in general. But the immune suppression from HIV really decreases the ability to clear HPV infection and leads to a higher rate of these pre-malignant lesions and a higher rate of invasive cancer. So how do we prevent this? Our best strategy is to prevent initial HPV infection with HPV vaccination, as was discussed briefly in the last session. The other thing that we can do is to look for, diagnose and treat these pre-malignant lesions to reduce the risk of invasive anal cancer. So again, this anal cancer prevention, which we'll be hearing more about in the coming months, the goal is to identify precancerous areas of the anus that can be removed to prevent invasive cancer. So you screen with cytology or HPV testing, just like we do for cervical cancer prevention. You diagnose with high-resolution anoscopy to really find these areas of HSIL, and then you treat the areas of HSIL with either ablation or topical therapy. And as a reminder, most cases of anal cancer are treated with combined chemotherapy and radiation. It's a very treatable cancer, but it's a very difficult treatment to get through. So here on the bottom, you can see an abnormal cytology with this coilocyte here, this abnormally large round nuclei with the rounded cell. And on anoscopy, here's an area that after application of Lugol's iodine is yellow. This is a small area of HSIL. So when that's found to be HSIL, you can then go back and treat and ablate that area to prevent the progression of cancer. So there's an ongoing trial, the ANCHOR trial, that was funded by the NCI, has been going on since 2014 or 15. What I can say is that the study is going to have an answer, and it's actually done enrolling, and we're done with follow-up. But the results have not been released. My understanding is there's going to be a press release perhaps this week to just give you a hint as to what the results have been. But this was designed to really definitively answer whether treating these areas of HSIL actually reduces your risk of cancer. And so this has been a huge, huge undertaking for a number of people. And I can say, regardless of the answer, it's great to have a question that's definitively answered. And those are the sites around the country. So for HPV vaccine recommendations, because it's an incredibly effective vaccine, incredibly safe. It's indicated in children and adults. It's the same for boys and girls, age 9 to 26. Generally, it's recommended to vaccinate at age 11 to 12, but you can vaccinate as early as age 9. And if you are not vaccinated at that age, then everyone should be vaccinated up to age 26. It's important to note that the efficacy of the vaccine decreases after sexual activity. The HPV vaccine does not really do anything for HPV infections that are already present. It only works to prevent new HPV infections. So it's critical that we support these vaccine programs, that children are given access and encouraged to get the vaccine at an appropriate age, that they complete their vaccine schedule before they start sexual activity. You may have heard in the last year or two that there was now a recommendation for adults aged 27 to 45. The ACIP, which sets the vaccination practices in this country, has termed this shared decision-making. So I think the important thing to note is that it's not really that, you know, anybody asks for it, then you'd say, okay, that's fine. It's really meant for specific people in specific populations where they really would seem to have a particular benefit for the HPV vaccination. Currently, we don't have data to just widespread support the vaccination of all people of this age. It's safe. There's no real concerns about safety, but it's really the cost effectiveness of applying the strategy in this population. The cost is probably prohibitive. Just a bit about oropharyngeal cancer. We have some data to suggest the vaccinations work for this. This was the study of a different vaccine, a bivalent vaccine. They did not look at oral infections in women during the trial. However, when the randomized portion of the trial ended, they did look and test for oral HPV infections. And what they found that women who had received the vaccine 4 years earlier had a 90% reduced prevalence of oral HPV at the end of the trial, which is really strongly suggests that the vaccine is effective to prevent oropharyngeal HPV. And then that is really the surrogate we have available to us to say it would prevent cancer. Okay, so to summarize, we talked about implementing screening for non-AIDS defining cancers, including breast, cervical, colorectal, and lung cancer. Lung cancer screening identifies cancer at earlier stages where treatment is curative. There's evolving data on screening for anal cancer that will say whether or not this should be the standard of care. And to remind you that HPV vaccination for prevention of HPV-associated cancers, you prevent a flurry of plethora of cancers, anal, cervical, penile, vaginal, and vulvar cancers with this strategy. And there are existing data to say that this would prevent HPV-associated oropharyngeal cancer as well. So thanks for your attention. I do want to point out, thank Anna Coghill, a terrific young scientist from Moffitt Cancer Center, and Elizabeth Chow, who both provided some input on this presentation. Thank you.
Bravo, bravo. Very well done, Tim. Lots of comments, and we have some time to go through this, so that's what we're going to do. One quick thing, a couple of the attendees mentioned in the chat that the U.S. Public Health Task Force in March or April updated the recommendation to now include people 50 and older with a 20-year pack year history. If they're over 80, they don't.
Thank you for that. I think they might have a different grade of evidence for that, but right. Yes, thank you.
So what, just I guess get practical, what would you do? You have a 50-year-old person who quit smoking 5 years ago. Would you go ahead and get a low intensity CT scan?
Yeah, well, first I would reread the U.S. Preventative Task Force recommendations to make sure I was completely up to date on that. And then, so I just ordered it for a patient a couple of weeks ago. And so ideally, the centers where you would order it would have a really organized program. I mean, it's similar to cervical cancer screening, right? That there's got to be a lot of quality control measures with this assessment. There needs to be special attention paid to follow-up. So if you find an abnormality, but no one gets further evaluation, you've really done no good. So it has to be really a comprehensive cancer prevention approach where you really take these abnormalities. Then there's programs to link them to the diagnostic evaluations and a treatment eventually. So yeah, it should be a pretty straightforward process to order this. It was for me at least.
Great. Well, we have lots of questions, so I'll try to read them quickly and get quick answers. We'll get as many as we can. Deb Cahal wants to know about, is a differential rate of HPV-associated cancers amongst HIV versus a general population decreasing with the expanded HPV vaccination in the pediatric populations? Are we seeing an effect yet? And I guess effectiveness?
Yeah, there are certain situations, certain places where you're seeing the effects of widespread HPV vaccination. Not surprisingly, it's in patients in areas that have a very organized, comprehensive approach to vaccination. So the first was Australia, where their genital warts just basically disappeared as a public health issue. And then other places are starting to see the rates of cervical HSIL go down quite dramatically. I don't think anybody's reported decreasing rates of actual cancer yet, but I could be correct about that.
Well, it's a little early, right? So Steve Bromer wants to know about metformin in patients with diabetes. They're seeing a little bit of a reduced cancer burden. And since his view is HIV and ARVs carry some metabolic consequences, do we know if there's any research on metformin and HIV? In other words, are we going to use it sort of like statins and do another reprieve style study just using metformin?
I have seen studies ongoing with metformin. I'm not aware of anything that would be at the scale to say that it would definitively reduce rates of cancer. So I don't know whether that we're going to have adequate data to recommend that widespread use.
Right. And the follow-up was any understanding of how metabolic dysregulation might affect increasing cancer rates?
Well,
biology about that?
I think there's intense research in the cancer field about inflammatory consequences of metabolic problems and the relationship between inflammation, these metabolic abnormalities, and the development of cancer. So certainly that's an area that people are studying pretty aggressively for prevention strategies. And as was mentioned, metformin seems to be a like.
Katie Okoa wants to know, do you consider a chronic cough in a smoker as a symptom of lung cancer, therefore needing diagnostic testing? Or is a chronic cough that's stable okay to do low dose CT? What would you do there?
I mean, I think it's your clinical judgment. If you think that this has just been present for a long time and there's nothing particularly worrisome for it, then I think that a low dose CT scan is the way to start. If you were not ever going to refer that person for evaluation because you're concerned about lung cancer, then I think it's fine to go down the screening route.
Yeah, that makes sense. Lee Lucas Neal wants to know about the frequency recommended for Pap exams on women with HIV.
So it depends. It depends on the age. So if you talk about women over the age of 30, there's two approaches. You can do 3 yearly Pap smears if they're all normal, then space out. I think many people would use HPV co-testing in that situation, so that if you had a negative Pap smear, a negative test for high-risk HPV, then you could space out the Pap smear testing or the Pap smear HPV co-testing, if you will, every 3 years. I would direct you to the CDC opportunistic infection guidelines, which you wouldn't necessarily think of that for cervical cancer prevention, but they have a really, really nice section on that that I think is very helpful.
Great. Jamie Weiland wants to know about, can you comment on HPV vaccine is recommended for those over the age of 65 living with HIV? And can you comment on the use of universal screening for anal cancer at any age for people living with HIV?
So the first question about HPV vaccination. So again, target is 11 to 12-year-olds. If they somehow don't get it up to age 26, from 27 to 45, it's a little bit iffy, but you would do it in some situations. Certainly if somebody felt really strongly about it, I wouldn't stop them from getting it. But above age 45, I don't think anybody is actually recommending that at all. For anal cancer screening, again, we'll have, a definitive answer whether we should be doing it at all. But if we are doing it, there is a ton of HPV, a ton of abnormalities for young people age 16 to 25, up to age 30. And the cost-effective modeling, which will now all be redone with the results of the anchor study, suggests that age 35 is probably the time to start. I feel very strongly, unless there's something specifically going on for young people, that you avoid anal cancer screening. It can be really a lot to go through. And I think in a prior lecture, they need to focus on ART and adherence and all of that at that age.
Yeah, true. Here's a quick question. Can a person clear HPV and then get reinfected?
Yes.
Yeah.
And there's 200 types of HPV. There's about 14 that we concern ourselves with in the genital area. So it's very hard to distinguish what's reinfection, what's new, but yes.
Yeah. John Phoenix wants to know about anal cytology. When we identify ASCUS, what's the recommendation for follow-up and screening?
At this point, any abnormalities, ASCUS and above, ASCUS low SIL, HSIL, ASCUS suggestive of HSIL, all of that should move on to high resolution anoscopy for diagnosis of HSIL if it exists, and to guide appropriate treatment. It could be very soon. It could be that HPV testing could help triage ASCUS, but so many people with HIV that we screen with anal cytology have HPV that it tends not to be so helpful. So basically you go from ASCUS to HRA.
Yeah. And, it's kind of fun and good that so many detailed questions are being asked, which to me implies a lot of folks are doing anal PAPs even before the anchor study is released here. That's great. So a patient with atypical cells on anal PAP and a positive HPV serology for high-risk subtypes, but was HRA negative. Should the patient be followed with repeat HRA endoscopy or repeated anal PAP? How would you approach that?
So I don't think anybody really has access to HPV antibody testing in clinical practice. I don't know of any role for that.
Right.
So if you do have HPV testing and somebody has HPV 16, that causes most of the cancers, or a lot of the cancers. So that's somebody that I probably would follow more closely with high resolution anoscopy. I think for people who do that procedure, you would be foolish to think that you would be able to find all HSIL with every HRA. So I think it's okay to repeat HRAs for people that you feel that you might have missed something, or other testing suggests that they have problems.
And I'll finish with this question. We noticed that most of the traditional cancers, prostate, breast, that type of thing, is not much different between the HIV population and non-HIV, but lung is twofold. And one of the things I remember reading years ago was that in certain lung tumors, they actually could amplify HPV virus. Is there anything to that? Do you think that might be a reason that we're seeing increased lung cancer?
Yeah, I mean, it's been written about, and I think several studies have found that association. I don't know if the exact mechanism of how the HPV would actually lead to oncogenesis is described that I remember. But it's another reason that certainly early ART, starting as soon as, hopefully some of these rates of cancer, as we now, more and more people that we follow were started at earlier and earlier stages of HIV. Hopefully we'll see some of this increased cancer incidence kind of diminish.
Yeah, fabulous. Well, you can tell by the number of questions, there's still several we couldn't get to. I don't know if you have time to maybe just go through and type in answers. That'd be great. Thank you. And thanks for a wonderful presentation, just really cutting edge and right on target for us. So thanks so much, Tim. We're gonna do like Liza Schuyler said in Hamilton, we're gonna take a break. We're not going to go away for the summer. We're going to go away for about 20 minutes. So we'll come back at about 20 minutes before the hour. Thanks for starting off a great morning with us. We got a lot more.